Welcome, everybody, once again to Rising Stars in Ophthalmology, Season 3, Episode 3. Let's jump into the episode, which is a very special topic to all of us, innovation and challenges in cataract surgery. But before we do this jump into the episode, let me just explain to the new members who are watching for the first time the format. Each episode, will feature one rising star around which we surround them with celebrity panelists, 3 celebrity panelists. Now, these are celebs. We're not talking about Brangelina, but we're talking about the people who really make this field of ophthalmology greater than what it, was. And it's their job to mentor these new stars or the rising stars into truly understanding their potential and, ensuring that we as moderators can help in this endeavor. This is a very interactive series, and we've always seen that the audience, as well as the panelists and the rising stars, can throw in questions and into the discussion, and we as moderators will help moderate these questions. So keeping to that, we're live on the website risingeyestars.com and on our YouTube channel called Rising Stars in Ophthalmology. The reruns of this, because it's a very global event, the reruns can be watched on our website risingeyestars.com. Don't forget to follow us on social media, Facebook, Twitter, LinkedIn, Instagram, as we also release some of the educational tips and snippets from all our episodes, which are the real juices that flow. I'd like to thank each and every one of you for tuning in live, and also thank all the sponsors for making this happen. And I could not have done this without, Jennifer Lowe, who's going to now introduce the speakers and the celebrity panelists. Jen, all yours.
Thank you so much, Ashvin. As always, it's an honor to get to share the stage with you and also all of our celebrity panelists and especially our rising star. I appreciate everyone's effort for tonight. I do want to first say a quick thank you to Dombe and the rest of our sponsors for this season. And I do want to also especially thank our partner, Young MD Connect. So before we begin, I am going to share a little bit of information about our celebrities tonight, as well as our rising star. So tonight joining us will be Clara Chan. She did college at Stanford University, med school at Queen's University in Canada, residency at the University of Toronto, and fellowship at Cincinnati Eye. She is currently professor at the University of Toronto, medical director of the Eye Bank of Canada, and president of the Canadian Cornea External Disease and Refractive Surgery Society. Her favorite animal is a dolphin, since 2 halves of its brain take turns sleeping, so the animal is always half awake. And hopefully she will be joining us in a few moments. Okay, so next up we have Dr. Stephen Dell, and he did college at the University of Texas in Austin, med school at Tulane University, residency and fellowship also both at Tulane, and his current position is medical director at the Dell Laser Consultants. And his fun fact is he once produced a major motion picture. Steve, would you like to share any information about this major motion picture?
Not really.
Okay. Just wanted to give you a chance. It's a pretty cool accomplishment. All right. Okay. And last but not least, we have Dr. Carol Karp. She did college at Brown University, med school at Brown University, residency at University of Michigan, Kellogg Eye Center, fellowship in corneal and external disease at Bascom Palmer, and her current position is professor of ophthalmology at the Bascom Palmer Eye Institute, and she's also the Richard K. Forster Chair in Ophthalmology and the Dr. Ronald and Alicia Lepke Professorship in Cornea. And her fun fact is she is an early bird, and she wakes up at 4:30 a.m. to cook and go to the gym, as she is an avid baker and athlete. So Dr. Karp, I know we're probably running a little on the late side for you tonight. Thank you for joining us.
Thank you so much.
Okay, and last but not least, of course, is our rising star, and that's Dr. Morgan Micheletti, and did college at University of Texas in Austin, med school Baylor College, residency at Emory, and he's currently a cataract, refractive, and anterior segment surgeon and the director of clinical research at the Berkeley Eye Center. I do have a few fun fact as well. Sorry. He and his wife went on their first date during their freshman year of high school. So that's a pretty long time. Did you guys stay together this whole time, or have there been some other relationships in the mix?
There's been bumps in the road, but no other relationships.
Wow, I'm impressed. Okay, I had to ask.
And they were all during high school, so everything. No, it's smooth sailing since then.
Wow. Okay, you are very loyal. I've learned a lot about you already. Okay, and you did share this really cute video with us. Do you want me to play? I'll go ahead and play it right now, showing your early start in eye care.
He wanted to look at his plate, so I looked down, but he had his reading glasses on, so he had to switch to his faraway glasses. Then he wanted to look at his dinner again, so he had to switch back. Then he got tired of doing that, so I went to the watch shop, got him to cut them in half. I got to show right there. You put the faraway glasses on top, which is right here. And reading glasses right here, so if you wanted to see your food, you would just look down like that. When you look far away, you would just look up. Ben Franklin,
So very cute video, and I'm happy to say now that you actually get people out of glasses, right? Sorry. And then I wanted to have you share your photos here that you've given us, if you want to say a few words about them.
Sure. So the top left photo was actually a mission trip to Mexico with Dr. Berkeley back when I think I was 13 years old. And then that was my first time scrubbing in at one of our current ASCs, which is kind of funny. So I was, scrubbing in to make sure that cornea stayed nice and lubricated. And then graduation day, first day at Baylor, white coat ceremony. We did like a zombie play during med school, and that's my wife next to me. She didn't think I looked any different. That's just how I woke up. And then the next day the next picture there was match day, so tagging Atlanta, Georgia, and then first day in residency, last day in residency with three of my mentors there, Dr. Yusuf Khalifa and Dr. Jeremy Jones, and then we had two kids during residency, so I was about to leave to do a globe, and my son hopped on the back of the truck, and so he took a fun picture, and then bottom right is Dr. Ralph Berkeley. It's one of my last pictures with Dr. Berkeley before he passed away. He would always come down the hallways, pushing his chocolate cart and handing, even after he had long retired, would still come back and pass out candy and just share happiness with all the staff at the practice.
Oh, that's really, really cool. All right. I think there's one more or a couple more photos of your beautiful family. So please share.
So top left is I guess my first dance with my wife. That was 2004. So we were juniors in high school, and then kind of through the years, show engagement photos, wedding photo, and then obviously everything about us now is obviously our three kids right there. So
wow, that's amazing. That's really, really cool. All right, and last round of photos here.
And this is just fun. So yeah, we do we do backpacking, and I like to do woodworking, and when we're not doing stuff with the kids. And of course, it's funny, all of my hobbies are starting to go downhill as the kids' sports are picking up. But this was just I thought that as we moved into fall, this was a great picture. This was actually around this time when I was an intern. I was on an ER rotation, and for whatever reason, it's something that I get excited about managing. So, this is something that's going to start happening more and more. We know that the annual incidence is well, we don't really know. That's the thing. It's hard to do a large study to figure out exactly how many, but somewhere we think between 2,000 and 10,000 in the US. And as we're putting in more and more multifocal IOLs, we know, or premium IOLs, even toric IOLs, we know that we're going to need to probably deal with these more. And it's not just going to be a monofocal where we can explant them and do a Yamani or some sort of scleral fixation with a 3-piece lens. And so one of the first techniques that I learned was a belt loop technique. And this is something I'm just going to show a quick video of, but this is the difference between having counter traction and or anti-torque and non-anti-torque sutures. So that first little bit there, you can see if the sutures are not placed correctly, when you let go, you start getting this tilt. And if you counteract the suture so that they're going in opposite directions, so up on one side, 180 degrees from up on the other side, in a split or kind of spread belt loop here, then you get more lens stability. So kind of a garage example. And then this is a patient who had a dislocated single piece lens, just creating some paracenteses here. And obviously they had a pterygium, which I went back later and took care of. But the first issue was obviously the dislocated IOL. So, and I'll fast forward through some of these, but essentially I'm taking a 30 gauge TSK needle and I'm going to pierce through right under the haptic optic junction inside, just kind of through the bag, and then thread some 6-0 proline and create a. So at the end of the case, you get a nice, well-centered 3-piece lens. Obviously there's some vitrectomy done. Now what I do in most of these cases, I'll go ahead and place a 23 gauge trocar at the beginning of the case, just because it helps from a management of vitreous standpoint. But that works great for single piece lenses, but what about for multifocals? You can do it, but multifocal torics, it's a lot easier if you can really grab the IOL and make sure that it's completely tethered and unable to move or shift within any sort of suture that's wrapped around it. And one way to do that is to actually puncture the IOL or pierce the IOL with the suture. Now, the problem with puncturing it with a needle is you get kind of this paper binder, the 3-ring binder punch through paper kind of appearance. And each one of these is a little tiny tear that can then tear out. If you pierce it with a needle, like a hypodermic needle, it creates a slice in the IOL, not exactly a round hole. And of course, these slices can propagate. So similar to how we create a rhexis, the most ideal thing you can do is create a hole. So, and that's the question, is there a way of creating a hole in a multifocal IOL or any IOL that can be used to fixate an IOL that could be used to fixate a toric or multifocal IOL instead of explaning it. And that's where, and I'm sure some of you have probably maybe seen this before because I've talked about it at a few other conferences, but if you utilize a punch, an intraocular punch, you can remove a core piece and get this nice round hole, which can then have suture threaded through it. And using the double flange technique, which was first described by Sergio Canabrava, as well as some others, you can suture fixate, right on axis, depending on what, where exactly in the lens you go. And so this is how, when I first started doing this, I would execute that kind of punch and rescue. Is I would go through the haptic optic junction, and then the suture's got to make that 90-degree turn and go out to the sclera, and that could lead to some tilt and things. So this was kind of the first video. The first case I had done, this was a dislocated restore lens. The patient got hit in the eye with a bungee cord, and there was kind of this anterior subluxation of the IOL. So this is the punch, and it's an intraocular punch. There are some extraocular punches, but this is an intraocular punch. And it's something that's patent pending, but it is also something that I've committed to any proceeds from. It's a very niche device, but any proceeds from it go to Grady Memorial Hospital where I trained. So kind of just something fun there. But utilizing this device here, I'm just going to create a hole at the haptic optic junction. And then I'm going to remove that core piece, which you'll see here. And I'm just using a second instrument to free it, because it is a little sticky once you punch through, and you get this nice round hole. And I'll fast forward a little bit. Now, this was one of the first times I did it. So I used a 27 gauge needle and 5-0 proline suture. It's really big. It's not something I do anymore. Again, this was kind of my first time testing this out. So I kind of went big in the literal sense as well. But it creates a really big flange. It's nice and stable. But again, you can imagine the amount of tilt, and I'm using high tint cautery, which I now use low tint, but you can imagine the amount of tilt that's put on that lens, the amount of forces that are put on that haptic optic junction in order to turn 5-0 suture basically 90 degrees and out into the periphery. But it worked really well. I just saw this patient about 2-3 months ago, now almost about 20 months out, and she is thrilled. She's 2025, sorry, and Jade 2, which is about where she started with that restore lens. So this is something we described and just recently published in JCRS, this kind of punch and rescue technique. And this is how I do it now. So this is a case that I had done about 2 months ago, and actually saw this patient back today. This is a toric lens that dislocated in the bag. And what I wanted to do was try to see if I could punch through the haptics horizontally. It was an idea that I'd come up with back in November and tested on some eye models, but never had a case to actually try it on. So again, this is just starting placing that 23 gauge trocar, and that lens is already kind of dangling. It's hanging on by maybe 2 clock hours as annuals. So if anyone ever does these cases, it's really important back, make sure you don't need to send it to retina from the onset. This one was really close, but I'm going to actually take the punch and go through the haptics horizontally. So now when I pass my sutures, I'm in plane. I'm basically converting this single piece IOL into a 3-piece IOL with the haptics in plane with the lens. So I'm really minimizing any torque. And what you saw in that first video is I had marked about 33 degrees away from the toric mark, which is just beyond kind of the bicep or the bulge of that haptic there, where I was able to then use my digital marker, my digital marker with, in this case, it's Callisto, to orient my scleral passes. And so 33 degrees away from my toric marks, I make my scleral passes, making that punch on both sides. And at the end of the case, I'll just kind of fast forward here, again, doing low temp cautery to create that double flange, both on the inside, both internally and externally, and just fast forwarding here, nice little bit of bleeding, but you get a nice, well-centered lens on axis, which is really cool. And this is a T5, this was a T5 lens. So, again, it's kind of something that was not really available. A lot of times this would have been, a Yamane technique. And then, hey, if the patient was really motivated, maybe you could do some sort of refractive surgery afterwards in order to treat their astigmatism. So that's kind of all I'll talk about kind of the middle vitreous or the middle segment, which is a great segment pioneered by one of my good friends, Christos. And so anyways, we'll segment onto IOL exchange. So Dr. Chan, what is your preferred method for removing an IOL? Because there's a lot of options, but do you have a preferred method?
Hi. Okay. Sorry, I had trouble unmuting. You'd think I get the hang of it by now. Yeah. So in terms of removing, I used to do the cutting and then, don't cut it all the way across. You could cut it like 2/3 and then pull it out, and it sort of, catches in the little, your incision opening a little bit, but you don't have to cut it fully. So then you don't have to take out 2 pieces. You can just do it at once. But then I started seeing videos about sort of this twist and pull out maneuver. And I started doing that. I mean, luckily haven't needed to do it too much, but the, 2 times that I've now done it, it's worked really nicely. I like it.
Yeah, that's that was not planned. I think that's great that that's what you do, because that's a little bit about what I'm going to talk about here. So this was the and we did not talk about that at all beforehand. So that's actually really cool. So this is the original twist and out technique that was pioneered by Dr. Pandit, Dr. Devgan, and Dr. Chapman. Essentially, you place the one haptic outside of the wound, and then you're using a spatula and a pair of forceps to then rotate the IOL. Really just roll it up, and you can pull it out of a 2-4. They even mentioned being able to pull it out of a 2-2. But it is a really big movement, and you can see, it's really taking the time to make this big, large movement. But the eye's kind of, moving around. While it's easy, it's still a really large movement. And so even in slow motion, you can see the IOL start to kind of open back up right before it exits. And this was my go-to technique too, just like you. But this is that big movement, and you can imagine that's a really big movement that you're doing while holding the other hand still. And this is their paper that they first came up with, and of course saw it on Cataract Coach. I think that's where a lot of people get their information as well. And so I thought, what if there's a way to modify it? So this is a restore lens. So earlier I showed myself saving a restore lens. Now we're explaining a restore lens on a different patient who was complaining of some dystopsies. But again, same thing, going to position that haptic out of the wound. But now I'm going to place, since I've already made 2 paracenteses, I'm going to go ahead and place just a 27 or 25 gauge cannula across the AC. Now I have both hands freed to rotate the forceps, and I can just pass it between my hands, and it's really simple. You can see the eye stays real stable, and this works with almost all IOLs, and that's kind of what I'll show here. So that was the old Acrosoft material. Now this is and this was a dislocate. This is an in the bag late dislocation of a Technis lens. But I'll fast forward to the good part here. So again, just going to position that haptic out, position that cannula across. And what's nice about this technique, and I'll show another technique that I think is really cool as well, but what's nice about this technique in particular is these are readily available instruments. This is a straight toothed 0.12 and just a cannula. It's a bent, you can use a bent cannula and straighten it. You can keep the bend. It doesn't really matter, but it's just a really nice atraumatic way to protect the endothelium and at the same time explant the lens in one piece. And then here's one other example. This is just an Invista lens. Now I'm going to fast forward here. One thing I want to show in this particular case, so let me get to the important part here. So when I placed the cannula across the AC, I actually placed it against the direction that I am going to rotate. So now when I rotate, so I'm going to rotate this back counterclockwise, and you'll see I actually drag the cannula back into the eye. So it's really important, wherever the hub of the cannula is, needs to be the opposite direction that you're twisting, or you'll drag it back into the AC, and then you won't get the same protection that you were looking for. And so when I started talking about this technique, a lot of people were saying, ooh, let's turn that sound off. Okay, so a lot of people were saying, well, this is something that a really stiff lens wouldn't work well with. I mean, obviously you're not going to do this with a silicone lens, but I've even heard people say when lenses are cold, you can't do it. So I took a model eye, put a Clarion IOL in, and took it down to 53 degrees, so non-physiologic temperature. And it was challenging, but you can get it out. So the point is, this is a great technique that can be used for pretty much all IOLs. And I think that's great that you were already using this technique. That's really cool. It's a great technique that Dr. Pandit and Chapman first developed. And it was kind of fun to add kind of my twist to it, if you will. That'll be my play on words there. Okay, this is a really cool technique. I don't know if you guys have seen this. Has anyone seen the reverse insertion technique that Dr. Wiley has presented before? This is slick. The only disadvantage of this technique is you do need some special tools, but you can see this is inserting a lens here, and this is kind of just a great video the way he set this up. But we'll go back and we'll talk about that. But here he's removing this IOL, and he's going to do a scaffold technique. So I'm gonna fast forward just for the interest of time. So freed up the old lens, new lens under it in the bag. He's going to free up that other lens here and position it. And now we're going to go in with these forceps through now, and what he's using now is an A cartridge. He's going to grasp it right at the haptic optic junction and just remove it. Nice and simple, nice and easy. And it's so smooth and so atraumatic. I think it's a really cool technique. And so that video you were seeing at the beginning where it looked like he was actually putting in another lens was actually just this video, but in reverse. So kind of a really fun way to present that there. I think it's super creative. And he had learned this. There was I believe this was done first by a surgeon in Japan, but this is kind of the special forceps that he ordered from Japan. And this was through, I believe, an ICL cartridge, but he's now using an Alcon A cartridge to do this technique. And that's just kind of showing that. So what do you guys think of that technique? I mean, if you have those tools available, is that something you would try? Dr. Dell, would you try that technique? What do you think?
Yeah, I mean, I think that if your incision is just a little bit larger, I don't even know if you need that instrumentation.
Mm-hmm.
If you have a sufficiently robust grasp of the IOL, you could just pull it, and many of these acrylic lenses will just auto fold and conform to the incision. You can just pull them right out. And I've certainly, many people have described that.
Right. And I think is that typically you think you can do that with a 2A, or do you think you need a 3.2 for that?
I mean, I think it needs probably to be closer to 3 something, but
okay.
The difference between a 2.8 and a 3.1 incision at the end of the day, especially when by the time you finish putting 2 IOLs through that incision, it's probably going to be 3 something when you're done. So why not make it the right size to begin with?
Good point. Okay. And then this is just to show that even with these cool techniques, sometimes you still got to bisect a lens. So this is a pre-lock-in LAL that I had to explant, and that silicone lens. So you just got to remove it piece by piece. This is a lens in a case of capsular phimosis. I could not dissect this thing out of the bag. I mean, I freed it up. I could spin it in the bag, but it was not coming out of there. And initially, it was a small pupil, or I could have used femto. I know Nicole Fram described using flax or femto-assisted capsulotomy late to treat cases of phimosis like this. But I actually had to, and I couldn't get an IOL under this one as well. So this was one of those kind of scary moments where you're like, man, I have to bisect this IOL in the bag and then pull it out. But fortunately was able to do it, just lock OVD and then get it out. And the last case I'll show here is just another scaffold technique. And we don't have enough time for this case, but this was just a fun, it's not often you see 2 different continuous range of vision lenses in the eye. So this was actually, I exchanged I removed a Synergy and put a Panoptix IOL in the eye. So there's a whole lot to unpack there that we don't have time for probably tonight, but it was a really interesting case. So just to show that there's lots of different ways to remove a lens. All right. So
Morgan,
Dr. Karp.
Morgan, Oh,
Yeah.
sorry, Morgan, before you move on, you brought it up before and when you showed your initial pictures, but I noticed that you did cut through the lens completely, and the ones you've just shown right now is a 3/4 or 2/3 across. Why did you decide to go all the way across and cut it and
Yeah,
then
great.
instead of a Pac-Man?
Great question. So in this first one here, it's a silicone lens. And so, it's so stiff that I feel like it's just easier to go all the way across. And then with the other one, which is this one right here, with that capsular phimosis, that bag, and it's tough to tell in the video, there was already so much zonulopathy going on that I was worried that if I didn't bisect all the way through that IOL and pull each piece out individually, that as I tried to Pac-Man it through, it would just snag the capsule and I'd have the entire bag IOL complex up in the AC with me. But normally you're absolutely right. If I have a lens that's freed and I'm doing a bisecting lens, I may only go 3/4 of the way across or 2/3 of the way across. Then you're absolutely right. You can just kind of rotate that right out. All right.
Morgan,
One more.
Yeah.
Oh, go ahead.
Absolutely.
I was going to say, Morgan, have you ever cut a locked in LAL? It's tough.
I have not had the pleasure or displeasure, but I have heard lots of stories, and I know that there are some great. I believe the recommendation is the Osher scissors. I think is what Nicole had some cool videos on, and basically they both grip and cut kind of at the same time. And she's had some really good success with that. I fortunately have not had to remove a locked in LAL. Most of the LALs I've put in have been post active shield. And so I fortunately haven't had any issues. Have you guys had any issues? I mean, have you had to remove an LAL post active shield?
Not post active shield, no.
Yeah. And so hopefully that's taking care of a lot of those issues.
Actually, I was just curious, for toric lenses, do you have a limit as to the white to white, like if to exclude someone from putting in a toric because they might rotate?
I don't, just because I really don't. Do you?
So I've learned this kind of the hard way, and then looking back, so there were 2 cases of mine that I had to like go back in and rotate, and both were pellucid marginal degeneration cases. And then I went and looked at the white to white, and they were greater than 12.7. They were like, oh, wow. One was 12.8, one was 12.9, or one was even 13.1. And then I went and looked at the lens diameters, and they're all like nothing. It's like 12.5 or something like that. So, right. After that, I'm a little bit more hesitant to do pellucid torics. Anyways, I was just curious since you're talking about fixation.
That's a great point.
Just a little tip in a high risk case like that. I've found that putting in a Henderson CTR, Bonnie Henderson's sort of
is better.
Ridged, will really prevent that from rotating.
Okay, yeah, I used like a regular. Yeah, I used a regular CTR and it still rotated. But maybe Bonnie's is like, because it has the ridges, would hold it. Yeah, great idea.
Yeah, for megalocornea and like your idea, Chan, Dr. Chan, any megalocornea, pellucid, hugely myopic eye, those are the eyes that tend to rotate and they just have a bigger bag.
Mm-hmm.
Yeah, great points. I'm gonna have to start paying more attention to white and some of these longer eyes, because we do get these 30 millimeter eyes occasionally that definitely have some both larger bags and larger ACs and larger white to white. So that's something that I'll start paying more attention to. All right, so this is kind of a unique case. Now, this is not something I deal with that often. I sort of manage this out of necessity. So every now and then I go down to about once a month or two, I go down to this small town about 2 hours outside of Houston, and I manage these patients. And this patient actually presented he came in complaining of cataracts, essentially. Well, he obviously had a little bit more going on than that. And so, I tried to get him over to MD Anderson, because fortunately they're right here in Houston. The patient did not want to drive anywhere. He really was limited from a social aspect. We tried to get him topical interferon or topical 5-FU. And of course, now there's, I know you can't get topical interferon is my understanding. And so it's a really challenging case. And so in a situation like this, Dr. Karp, what is your preferred treatment? If you can't get this patient topical agents, he's got trouble getting to surgery. Is there anything else that you can think of? I mean, obviously we want to try to get him to surgery, or at least try to, if we could get him on drops or find some charitable way to do that, that'd be awesome. But you're also concerned about compliance, because that was the other issue in this case. I was really concerned about compliance. So any thoughts here?
So, I mean, I guess my first choice, if this is not this particular gentleman that was not compliant and all that, but I would say in a large OSSN in general, like the one you're showing here, I would try 5-FU as my first choice, because it is so inexpensive and so easily administered, because I do 1 week on and 3 weeks off, and 1 week on and 3 weeks off. So compliance is so much better, because they only have to do it 1 week per month. We give it out because it's something that we have a little fund, and it's the least expensive. Right. Whereas, as you already mentioned, interferon is so awesome, but is not currently available. So that I love. But if a compliance is an issue, one thing that you can do is you can inject interferon, let's say when it wasn't available. And as long as the patient came in, then you could be sure they got the drug, because you would inject it into the lesion. And interferon would be my favorite way to do that. Although other drugs have been injected that can work, whether it's 5-FU, although I really haven't found consistent success when I inject 5-FU. Like with injecting interferon, it works awesome. And so that helps with compliance if they're just willing to come in. But then in this kind of case, then I'm not sure why he said he wouldn't do surgery either. He wouldn't do.
So the problem was him getting there, and that's what a lot of this came down to. Is he had no one to drive him, and there was just a lot of. It's a long ways, and he actually lived. So that's the clinic that I went to. He actually lived 2 to 3 hours away from the clinic. So we're talking 4 to 5 hours from the surgery center. So, it was going to take some time. He had some family that lived out of state that he was going to try to arrange to come and stay with him, but he didn't know when that was going to be. So I'll tell you what I did. So I made a call to, I talked to Jill Wells, who's at Emory, works with Dr. Grossenklaus. And, she was like, well, do you happen to have any Avastin? And I was like, I do. And I was like, I don't know. I mean, what do you think? And we talked about how it doesn't really work super well for corneal extension like these cases. But, at the time I talked to the patient, I was like, I don't really know what else to do for you. I have this here because retina comes here. We can give this a try. And so I went ahead and gave him the 1.25 milligrams, and I gave it above the lesion. I didn't want to get anywhere near the lesion. So I gave it to him superiorly, and kind of was hoping the gravity would kind of let it just settle down. And I was just curious, have you used Avastin before in a case like this, either topically or subconjunctivally?
So I have, and it is been written about, and with sort of mixed reviews, as you just mentioned, that sometimes it works and sometimes it doesn't work, but it definitely anti-VEGF, and these tumors want to be fed. So I have used it in the scenario that I want to try to cut off the blood supply. I have to see if, trying something that another agent wasn't working. It wouldn't be my first line, but because especially in this case, you had to do something. Like I said, an injection is a good idea when you have the patient there and you can do something. I think that is, it can be helpful. And I've also used Avastin when I'm taking out the tumor, and then use Avastin to help with vessel ingrowth. So it can be a adjuvant or neoadjuvant to treatment.
Yeah. And so this was 2 weeks later, and I was shocked when I saw this. And then I saw 2 weeks after this. So now he's 4 weeks from the first dose. still didn't have much support. So I gave him one more round. And so total of 3, and I don't have a picture of all of them. This was at one of the next visits. So overall, just relatively remarkable improvement. And then finally, so from the time when I first saw him to the time I got into the OR with about 3 rounds of Avastin, it took about 4 to 5 months, but I finally got him in, and I don't have a video here, but I did do a double free, just a no touch technique. So I did absolute alcohol, 2 to 3 millimeter margins, followed by a partial lamellar keratoscleroconjunctivectomy, which is always a super fun word to say, and a double freeze thaw. Fortunately, we have retinins, so we had at least a cryo unit, and any surgical pearls for this. I mean, obviously, no touch technique, and minimizing manipulation of the tissue and BSS and everything else. But any pearls that you have in these cases?
So that was perfect what you mentioned, like that trying not to touch the tumor initially. Of course, you have to eventually. That's perfect. And keeping the field dry so that you don't spread cells. Another thing I like that you mentioned is using the retina probe. So people say, oh, I don't have cryo. Well, we just borrow it from our retina colleagues. If it has a sleeve, you take it off, and it works perfectly. Just to get more bang for my buck, I'll turn it sideways where you put it. It's perfect the way you did it, but I will turn it so I'll drape the whole edge of the conjunctiva over my stick so I can freeze a whole bunch of the conjunctiva at once. And I freeze the limbus, because really the limbus is probably very important, because that's where the tumor arises from. The only thing I would say that I don't do is that I don't cut through Bowman's. Bowman's is my friend, our friend, because in general, the tumor will not go through Bowman's unless it's mucoepidermoid. So I use alcohol, as you said, but I will not actually cut out. I will always leave Bowman's layer there. So I scrape it all the way to the limbus, like bulldozing, and I will take sclera if I need to, but I love Bowman's. The Bowman's helps prevent any future. So that's perfect. And then closure. You didn't mention how you closed it.
Yeah. So in this case, yeah. So in this case, I just I used AMG, just amniotic membrane, and some to seal.
That's perfect. That's actually my preferred, because I like to keep the margins where they are. So that way, if my pathologist says, superior margin, I'll know, because it's right there at the edge of my of my MT. If you sew them back together, sometimes you're like, now where is the superior margin? The other thing I would mention as a pearl is, whatever you take off, always orient the specimen for your pathologist. So I'm sure you did this. You just put it on a piece of paper and label it with pencil, so that then so often people just throw it in and it gets all rolled up, and it's really hard for the pathologist then to say what is what.
Right.
So
no,
I think that was handled perfectly. The only other little pearl, which Carol Shields gave me the idea for, which is, you have your glue, which you said you used, and then this epithelial defect, is do a bandage glue. So just spread the cornea with a little bit of your fibrin glue, and then they're so comfortable after your scraping procedure. So it's just a little trick that makes them happy.
Yep, and I do that actually I do a fair amount of Teresian, so I always do leave with just a little bit of fibrin glue just right there over that defect. So this is now 1.5 years later, and he's doing great with no signs of recurrence, and we're just kind of monitoring him, and he's happy, but he was actually happy when he came in. So fortunately we were able to take care of this, and we didn't inconvenience him too much. Okay, so let's talk about. Can I
ask a question? Is your preference to use fresh frozen amniotic membrane, or dehydrated, or cryopreserved?
I like I like. Yeah. Oh, was that for Dr. Karp or for me?
Anyone.
I'll let Dr. Karp answer. She's the expert.
I definitely like the frozen. I think that the dehydrated is dehydrated is great. Like if I'm in the clinic and I have a KED and I want to put, an ambio disc, I don't have any financial interest, but if I use it dehydrated and then put a lens over it, that works great. But with these tumors, I really like taking the frozen, peeling it off. It's much hardier, thicker, and easier to work with. So I like that, and I think that's what Morgan was just going to say, that he uses it. It's just very easy to handle, and they heal really nicely. The anti-inflammatory factors are great. So,
All right,
is that what you're going to say?
Yeah, that's exactly what I was gonna say. I do like the frozen. It's just a lot easier to handle, and it's quick and efficient, which I prefer as well. All right, so I think we're starting to run out of time a little bit here, but we'll kind of move into toric rotation. So Dr. Dell, you've got a patient who has a toric that's rotated off axis. You're noticing it in clinic. Let's say it's post-op day 7. What's your preferred management? How do you like to handle these?
Well, when I know that the lens was originally in its correct position and then it moved, I have access to a minor OR in my office, and I will sometimes just take these patients, lay them down, take a hypodermic needle after prepping the patient, and engage the IOL and move it. Some people also describe doing this with the slit lamp, but it's remarkable how easy it is to do this, just going straight through clear cornea with a needle, and you can engage the peripheral toric lens and put it where it belongs. So I think that's how I handle those typically. If the patient dislocates very late, that's a totally different story. But in the scenario you proposed, that's how I handle it.
Right. And now I'll talk about. Oh yeah, go ahead.
I'm sorry, Dr. Dell. How long would you wait and still try this without going in to try to lift it off the lens, etc.? So 1 month or
4 to 6 weeks. I think that I might try it at maybe 8 weeks, and if I started to encounter resistance, I thought it was difficult to free up from the bag, then I would abandon that. It would also depend a little bit upon the brand of the toric lens, if it has terminal bulbs or not. But I think in the stickiness of the material. So for example, Technis platform would be different than the original Acrosoft material, and the Clarion material sort of in between those two in terms of stickiness. But the absence of terminal bulbs makes it easier to rotate these lenses in the sort of medium postoperative period. But at a week, you can rotate any of them quite easily.
Yeah, no, I think that's really cool. I haven't done it at the SILAMP yet, but one of my colleagues at our practice has, and I was very impressed by it. I thought it was a really cool way, a really convenient way for the patient. And obviously with proper sterile procedure, it can be made really safe as well. So one other thing I want to show here, this is very different than what we just talked about, but this is, when you're in the OR and you've got it lined up, all the OVDs out, and then all of a sudden it just moves just beyond your marks. And I'm going to fast forward here because obviously we know we can go counterclockwise when those haptics aren't folded yet. But what about when all the OVD's out of the eye and it's in the situation, a lot of the thought is you have to go all the way around. And so one thing that I found, and I do a lot of chopping, but if you just go out to the periphery and real gently sweep that haptic back centrally, if you're beyond the axis, and again, there's no OVD. So you just kind of want to be real gentle with this, but it's like having an AC infusion, and you can real gently pull those haptics in and rotate it and realign your haptics. And so it's for me been a really nice way when you get a late rotation in a case. Obviously, this isn't days later, but in a case, it's a really nice way, and it works with all different manufacturers, depending, regardless of the IOL shape. It's just a really nice way to have to be able to go back, 5 to 15 degrees as opposed to rotating all the way around, basically 100 or like 150 degrees. So do you guys utilize that at all? Do you ever reach out there and bring a haptic back in? Some of the lenses just rotate, like I've noticed the Invista lenses will just rotate counterclockwise anyways if you sometimes floor it on the INA. But the other manufacturers, those I sometimes have to nudge, like I showed in these videos.
Yeah, Morgan, your
I think that was
technique is really nice. Yeah, go ahead, Carol.
Yeah, I was just going to say that's just a great thing to me. Also, I just can't stand when, I feel like, oh no, now I'm going to have to go all the way around. I have no viscoelastic in. Do I have to waste it and go in and blah? So I think exactly what you're doing. I've tried. Just pull it in a little bit, and then you can shimmy it back in that direction. And the other thing for the residents that are listening there, it's important to remind your scrub tech to lower your flow rate. So when you're taking out the viscoelastic, put your INA on top of the lens to try to keep it from vibrating too far after you've made it kind of close, but not right on. And when you lower the flow rate, then there's less turbulence and less likely that the thing will then go beyond the area that you want, the axis that you want.
Morgan, I was going to point out that your technique is really great, but if you just engage the IOL in foot position 1 and pull the optic sort of centrally, if you pull it centrally, you can actually go counterclockwise. It's a hard maneuver to explain, but as long as you're in foot position 1 and you're really inflating the entire peripheral capsular bag with BSS, you can pull the optic centrally and then sort of push it counterclockwise, and then engage the part of the optic that's in your lap, pull it centrally, right, and do the same thing. And you can walk it backwards. I never go all the way around again, and did that for years. But using this technique, pulling it centrally, centripetally, you can rotate it and achieve what you're after. And another trick is that if let's say you're just shy of your marks and you need to go a bit clockwise, if you just go into foot position 1 and then tap on the optic, the lens will very slowly rotate clockwise, and then you can sort of stop where you want it to be.
Right. Yeah, those are all great points. And I've done that too. I kind of think of it like the one time in residency when I implanted an ACIOL, that same kind of maneuver that you're doing in terms of walking it backwards. That's kind of what I think of when I hear you talk about that, and I utilize that sometimes too. I think the biggest thing is making sure that you remove OVD, because what I realized is those, when you get that lens that you think everything's settled and you're about to get out of the bag, and then all of a sudden you get that little bit of movement, it's almost always because there was, either some fluid currents, a large bag, or a lot of times just some OVD that didn't get, removed properly. So I always get behind the IOL, especially in toric cases, remove all the OVD, and then I position the lens. And I really like using that bimanual technique where I'll put my chopper through the side port, and once all the OVD is out, I'll position it that way. It's been a lot more efficient. And I know that there's no more OVD left, and I can count on one finger the number of times I've had to go back and rotate a toric IOL, because I think that by really making sure that bag is as opposed to that IOL as it can be prior to getting out, and that's not always possible, obviously, with if you have a white to white of 14 or something crazy like that. But that's been helpful for me. So I did want to highlight some other cool technology that I've been utilizing a lot. And before we go into that, so Dr. Chan, what is your preferred technique for creating a capsulotomy in a patient with white cataracts?
So if it's a white cataract, essentially with like very milky, I stain with Vision Blue, and then I decompress using a 25 short needle. That's just sort of bent so that it's more ergonomic on a TB syringe filled with like 0.3 of BSS. And then making sure that the bevel is down, I go in and I decompress and pull back. And then that sort of, decompresses the bag, and then I can proceed with a Rexus as normal. I always ask for Heal-On 5 as well, and I put that in after the cohesive viscoelastic, and then that kind of flattens everything out. And you want to see the lens going from, bulging forwards to like concave, is that the right? Anyways, bulging down so that you're working sort of making sure that the lens is downhill so that it doesn't roll out and you don't have a run. But the key thing I would say is for me to make sure that the bevel of the needle is down, I made the mistake once where I tried to do the maneuver and I forgot to pay attention and the bevel was up. And as I punctured, it split and had an Argentinian flag. So that was not fun.
Yep.
So you want bevel down so that as you're sucking and getting the decompression effect, the whole needle is actually like in, facing the white material. I don't have the Zepto. I've used it a few times in a trial, and it's really neat. I do like it, but we don't have easy access to it.
Yeah, and so that's exactly what I do or I used to do primarily would be needle decompression, just like you described. And I think one thing that I that I ran into a little bit of trouble with, at least once in residency, was not going deep enough, right? So I'd get in with my needle, but then I would start aspirating. And while aspirating, I would actually engage some of the capsule, and then I'd start pulling back, and then I'd have something tear out. So I think a great tip is to make sure you're deep enough in there that, bevel down deep enough in there that you're going to aspirate the liquefied cortex and then release tension. So that way, as you come out and go back past the capsule, you're not aspirating capsule into your needle and then ripping out, because I have been guilty of that before. So here's a cool video. This is just a white cataract. And this is Zepto in a lot of different cases. One of them is a white cataract, and this was a patient who ended up with a trifocal lens. But what's so cool is by neutralizing all the forces, it's applying vacuum onto the capsule, which also decompresses it. So as soon as that capsulotomy occurs, that suction that's there is instantaneously decompressing the bag all at the same time. And so it's just been a really cool device. It's actually relatively inexpensive technology, which is really cool. So this is another what I found to be really cool use of the Zepto. I'll fast forward back to where I was, is in small pupil cases. So this is a case where, hey, look, I can go in, fit it inside this iris, and create my perfect capsulotomy. And this is another premium lens case. And I know that I'm going to have a well-centered rexus, which will lead to a well-centered lens. And I'm kind of jumping around here, and you can see, no ring was necessary. And it makes it really, really simple and straightforward and atraumatic for the patient, because that silicone sleeve is really traumatic. Here's just another example. Again, small pupil case, no ring necessary. Once I get a capsulotomy and leverage horizontal chop, I feel like I can get through most size pupils without much issue. So I've really enjoyed using this technology, both for white cataracts and then also small pupil cases. And it's been really fun. Dr. Dell, have you tried this at all, or what are your thoughts?
I have tried it, and I don't use it typically, but it's really cool. I'm wondering, Morgan, have you ever tried just engaging a white cataract into your capsule with the phaco tip?
I have.
And
I have done it. So phaco decompression. Yeah. So, and I've for me, I have a Centurion, so it's just making sure you're in chop and always staying in linear. And so that way you don't get any kind of that ozzle rotation going. But yeah, I have done that, and it does work. Although I feel like this is a more controlled, at least in my hands, it's a little more controlled method.
Hey, Morgan, just from a timing standpoint, we got to close in the next 3-4 minutes. So let's look to show the last case, and then we'll close up after this.
Sounds great. Brilliant. So yeah, so this is just kind of moving on. Since we kind of talked about small pupils with that Zepto device, I kind of wanted to talk about basically inserting toric lenses and then having a small pupil. Visualizing those toric marks in small pupils are kind of hard. Sometimes it's too late to put in, an iris expander once you already have a capsule, depending on the device. So Dr. Dell or anyone else, do you have any comments or any tips on how you like to visualize those toric marks in a small pupil?
Oh, so in other words, this is a patient, maybe we're putting in a Malyugin ring, and then we take out the Malyugin ring, but we've got to make sure the IOL is in the right position. Sometimes what I'll do is I will take, before I remove the Malyugin ring, I'll take a 27 gauge needle, and I'll make an indentation mark in the IOL that's more central than the toric marks. And I can see that, and just sort of, and that's for a very small pupil. For a pupil that's maybe 3.5 to 4 millimeters, you can sort of pull the IOL in one direction, see where the mark is, pull it in the other direction, see where the marks are, and you can line it up that way. But when it's really small, I'll make some temporary indentations in the IOL with a hypodermic needle.
That's cool. I hadn't heard of that before. That's really cool. I'm going to have to try that.
That's a great idea. And I don't know, before the times we had the Malyusian rings, we used to use something called the beeler. I don't know if you've heard of the beeler. It has three fingers. You put it in. It's and you advance it, and then the three fingers come out, and it basically spreads and lets you see everything, and then it comes back in, and it's a non-disposable. So I can always have it in my room on my small pupil cases. It stretches things open. You can take a peek, make sure everything's okay, and then out it comes.
That's really cool. So I was running into this quite a bit because it takes a lot for me to put a pupil expander in nowadays. So I kind of came up with this new chopper, and I wanted to combine both a Cybele, but kind of something that was offset, and I could do this twizzle motion because our scopes are getting, they kind of get bigger and they get smaller. So the room under the scope is starting to become diminished. And so the idea is you can kind of twizzle this, but then you also have some different notches that kind of works it's like a Swiss Army knife of choppers, if you will. So just to kind of show this is just kind of it in use, being able to use it in the case, and then also be able to check your pupil marks. Obviously you could do this with a Kugelin or some other devices, but it's kind of nice to just, if you had one device to have in the OR with you, could this be it? And so and it's actually bag friendly. It looks like it kind of would be aggressive, but you can see I actually, instead of moving it in plane to chop, I kind of twizzle it. And so it's kind of this more twizzle chop, because that's where the cutting axis is. So it's just, and it's still super friendly on the bag. And then I'll fast forward just to show some more, let's see, I think I have another small pupil. Yeah, here's just another example. And again, this one's not too bad. These aren't great examples, but if you were wanting to check that axis, real easy to just kind of go out there and check it in a kind of atraumatic technique. So anyways, just something that was kind of fun that I had worked on that I thought was kind of cool. But
that's great.
Well, thank you all so much. I've really enjoyed learning from you all. It's been a pleasure, and thank you so much to Rising Stars for this opportunity.
Thank you so much.
Great presentations.
Thank you.
Great job.
Beautiful family.
Great presentation. Thank you.
Morgan, that's been absolutely brilliant. To be honest, we learned so much from you. I don't think it worked the other way this time. So thanks, Morgan, for that brilliant talk. I think we, from the audience perspective, we learned a lot from this conversation. And I think what grew from a conversation from IOL exchanges, we spoke about OSSN and how Avastin is used in toric rotation, Zepto cases, small pupil, new chopper. I think it's a potpourri of different topics that Morgan is doing. I'm sure that if I had given him another hour, he would have gone on with a few more topics. But unfortunately, all good things, or let me put it, all great things have to come to an end at some point. And also a lot of people across the borders from where I live are very sleepy right now and want to go to bed. Dr. Chan, welcome. We didn't get to introduce you in the beginning, but we showcased your work as well a little bit in the beginning at the introduction. But the point which I'm trying to get at is it's been an exceptional episode for us. We do wish and believe that you guys will see us in the episode 4. Thank you very much, audience members, for tuning in. Obviously, the people who are going to be tuning in for the rerun, since it's a global event, a lot of people will be time zone specific. So keeping that in mind, I'm going to call for a close. Thank you, sponsors, for doing this, without which it's not possible to be here. And most importantly, thank you, celebrity panelists, for all of your support. Dr. Dell, Chan, and Dr. Karp. You guys are exceptional in your work, and that's why you're here. And really, my last and final thank you to Bill Trattler and Jen Lowe for doing this and helping me, moderate this session with you guys. Calling for a close. Thank you very much, guys. Thank you all. Best of luck and see you soon.
Thank you.
Bye-bye.
Thank you. Thank you, everyone. Great job.